February 12th. And this afternoon, we have our first budget review, department budget review. We have Diva in today. So Stephanie and Deshawn, if you'd like to.
And I can share.
Welcome back.
Thank you.
Whenever you're ready, you can start.
I'm Deshawn Gross, the Diva Commissioner.
I'm Stephanie Barrett. I'm the CFO of Diva. And then we have a few folks helping us.
Sandy.
Hi, Sandy Hoffman, Deputy Commissioner of Diva.
Good afternoon, Alicia Cooper, Director of Managed Care Operations for Diva.
Joining us today.
So I know we are tight on time, and so, or at least Stephanie's time, and we'll get but I really wanted to kind of really give you a kind of a high level overview of our accomplishments from 2024, and then we can go into the ups and downs, or we can go straight to the ups and downs if you prefer.
Do you want to give us your high level and then
The highest level? So over the past year, we've made very good progress. We've completed the post-pandemic Medicaid renewal start with the 75% retention rate. We implemented 12-month continuous Medicaid eligibility. We secured federal authorizations for Medicaid funds to support housing, spearheaded the state's response to the Change cyber attack. We remain committed to value-based payment programs, and we have done this since 2014. We have a number of value-based payments through in the planning, design, and implementation phase that are currently underway. Our biggest one is the Vermont Medicaid Next Generation, the ACO, so OneCare. We're continuing to work on modernizing our business and information technology, our Medicaid management information system, and we are in procurement with the Integrated Eligibility and Enrollment Program, our VTIES project that is currently underway. I want to stop there because I want to save time for Stephanie to kind of go through her time commitment.
And Leslie, did you have a clarifying question?
Clarifying question, you went by that really fast.
Yeah.
You mentioned the ACO, which I believe is going to be winding down, so I wasn't sure how that fit together.
Yeah, so the ACO ends at the end of this year.
This calendar year.
This calendar year.
Yeah, 25.
Right.
So what did you just say about that?
That was one of our value-based payment programs that we had.
But it's going away.
That's going away.
And you're happy,
Yeah.
that's all you were saying. You were successful, but it's going away.
Exactly.
Got it. Thank you.
But the money we paid them is not going away.
Well,
That's
that is-
okay.
Oh, cool.
Just to be really clear. So I don't know I know you're having printed documents coming, but if you are looking at our budget book, the ups and downs start on page 61 and the narrative starts on page 48. Or there might be individual ups and downs posted that folks can.
We just start on B306, but we have.
Yeah, we can do that.
Yeah.
So B306 is our admin budget, and the light in this room is so much better than House Appropriations for reading things. And the admin budget covers all the costs of operating Diva. So it's our 372 employees and all our overhead operating costs, and then all the contracts and IT system contracts that we pay for. So even if we don't hold the contract and the Agency of Digital Services holds the contract around a project for one of our major IT development endeavors, we pay the bill on those. And so that's what's in what you see in B306, which is totals $182.3 million in total. And most of these should be fairly familiar as we run down the ups downs from budget adjustment. But we start with our salary and wage costs. This is the rollout of the Pay Act structure. So that's, a Pay Act is enacted the collective bargaining unit provisions that impact our employees are funded by an allocation, but they have to be built into the base the next year going. And so that's what you see in our first line of the ups downs, which totals $2.1 million across all funding sources. $871,000 of general fund. And then you see associated fringe benefit costs. Some of these are driven by the Pay Act because they're tied to the percentage of your salary, like retirement. And some of them are the nature of what it is, like healthcare. If the cost of healthcare is going up for employees across the state. And so that gets rolled into our base each year. If you were looking at any other agency's budget, you'd see very similar, line items for these costs. And so you see our healthcare costs, our retirement costs, our employee, there's a small amount of other, like your wellness and dental and other pieces rolled together of all the other employee costs. The cost of the Family Medical Leave Act and the cost of the child care contribution, and our workers' comp cost. And we have no change in our vacancy target at all. We have a vacancy target that's in the 3% range. We're maintaining that vacancy target. And that sort of covers the entirety of the staffing budget. But also in the personal service line of the admin budget are the contracts that are held by DEVA. And there are many of them. And there are some adjustments to those. Legal aid we talked about in the BAA, it's not a change to the total, it's a change where it's living. It's coming up from the program budget into the admin budget. We have a net change of funding, and you can see that it equals to 0 over on the far right, but we have identified, areas to maximize federal funding under our advanced planning documents for projects that are specific only to Medicaid and not blended like with other parts of state government where we get a lower match rate. And that's what you see in the DEVA held contracts net funding change to Medicaid only advanced planning document. And that was we had the same line in the budget adjustment. We do have a new contract. We had to go out to RFP for our call center in our KU unit. So that started last year and went through the summer with response. And so we have entered a new contract. It is not a new vendor. We ended up picking the same vendor, but that contract comes with a slightly higher cost. And that's and that will start for July 2025. And that's what you see on the call center contract, new cost to our budget line. We have a small adjustment for some functionality in another contract related to the exchange coming up in the early part of the new fiscal year. We have an amendment to our MMIS system with our fiscal agent that has a cost associated with it coming onto our budget. And then the truly new piece in our admin budget is the final line under staffing, under personal services. And that is funding for 8 new case management positions in the VCCI program, which is funded in DEVA, but is very much, directed and aligned in the central office. And that's for the Justice Reentry Initiative, which we got approval for in the waiver a year ago, and is building toward, turning on in January of 2026.
That's the waiver that we received so that people in Department of Corrections under there can receive Medicaid for
90 days.
90 days
Prior to
prior
being
to being
released. Yep. And then we have in our operating budget, a variety of operating expenses. Most of these that you see, fee for service, the insurances of the state, the vision system, which is the accounting system of the state, the ADS associated charges, the human resource services. These are basically internal service fund overhead charges that all departments have, pay to make sure that we are, fully drawing our indirect rates under federal grant funds and things. And so these are just, they're relatively modest. You can see them across the ups and downs. We don't have a control over them. They're basically, function of the formulas and the usage that we experience in those areas. And then we have the same adjustment that you saw in our budget, this $8 million down, that doesn't affect any program line. This is a correction to our underlying over appropriated spending authority in the federal funds line in our operating budget. It doesn't, it's the same exact, it's been wrong for a couple of years. We've been trying to get it to the right size. And so we're taking $8 million of just spending authority away. We won't be able to earn that. We don't have it's a miscalculation from several years ago on the match need that we thought we had in our admin budget. And so it's the same exact item that you saw in the budget adjustment. It's just that the budget works from what you passed last year to what we're proposing this year. So that's why you see it's not a change to the budget adjustment. The budget adjustment is just this mid-year correction. And then finally, we need we have the same impact that you see of zero on maximizing federal funds under our advanced planning document. And then the new staff for VCCI also need to have, computers and equipment to function. And so there's a small adjustment there. And so that's the picture of our admin budget. It is very much steady state with the exception of the 8 new positions in the VCCI for the Justice Reentry Initiative.
Can you remind us, can you remind us what was passed fiscal year 2025 for administration?
Yeah, so it's that top line, the one in the yellow.
So it has changed not one bit.
Yeah, that's what you passed in May.
Okay. And it's still 182.
Am I reading it wrong? Total after.
82, 283 as opposed to 182, 212.
Yes, that is. So it's still roughly the same number. When we were in budget adjustment, it actually dropped down. The actual appropriation with the budget adjustment you passed dropped that 182 in the yellow down to 179.
Okay.
But the way the budget system works is you go from what's enacted to what you're proposing to enact next. But if you went from what you enacted to what BAA was, you'd be going from 182 to 179 back up to 182.
Go ahead, Lori.
Just a question on the 8 additional staff, and just remind me when the waiver's starting, when we expect the staff to start. How does it all line up?
So we expect the staff to come on in the early part of the fiscal year.
Okay.
But the program turns on for January 2026.
Thank you.
Anyone have any questions about administration? Easy.
I'm surprised, there's nothing on vacancy turnover savings. I don't know.
We have a set amount that's 3%. And so if that was changing, we would show the incremental change, but there's no change. That's why there's no amount in that line. So these are only incremental changes from the past budget, what you enacted. And so our target for vacancy savings is 3%. I can get you the total of it. And what we're saying is we are maintaining that 3% target.
Yeah, it's hard for me to compare that with, last year. I think we didn't have the 3%. There were actually numbers in there, if I remember.
So we actually had a much higher target last year. And if you went through our budget bill from our budget presentation from last year, you would see that we said, you need to give us more money because we actually have a lower vacancy than what's baked into our budget.
Yeah, right. So can you just send us something
Sure.
so that I can compare that? Because right
Sure.
now it looks like there's no.
So what you want to look at is what the
There's no savings is what it looks like. So I'm during this transition.
But that's not, yeah, that's, I mean, no, that's using it. There is an amount that we budget for every position. And then there's a negative embedded in our budget, and that negative is not changing at all, but it is there. It is an amount that, because we always have turnover with 372 people.
Yeah.
It's just in that 3% range, that instead of, I think it was at 6% when I came on last year, and I came in and said, you need to add to our budget because our vacancy is more like a 3%
Which is significant at AHS, right? Or at DEVA, right? 3%
It's a significant difference because we were successful in maintaining, people staying in their staying employed with us.
Sorry, I just have one more question. So while the overall number only changed by 70,000, am I reading this right, that the general fund dollars needed for this new
Yes.
budget is 3.9 million?
Exactly. And I did want to, the total is one thing, and it's a little bit, the $8 million down in federal is changing the perspective of the total when you look at our admin budget, because that is absolutely true. It's almost $4 million up on the GF side.
I'm gonna ask a question and you may not know the answer, and that's okay.
Okay.
And this is just for my personal knowledge, because we think about this all the time. You have 1.355 million in health insurance for employees.
Yes.
Do you have a sense of what that was last year?
We can get it for you. The rates are set every year and rolled out, and they're actually sort of baked in by finance and management into the system. And this is what the system pushes out for us, but we can show you what we can get that for you, what the state employees' health insurance change. There's probably a report from finance and management on it.
That would be terrific.
And now we're switching from our admin budget to our program budget, which is where it's a much bigger. And I'm going to switch a little bit back and forth on the narrative, because there are some, I've summarized things on the narrative. For example, our caseload and utilization, which has a line in each of our programmatic budgets. The biggest one being in the global commitment program budget of $46.1 million. Similar to the budget adjustment, a very substantial increase in the FPAS budget. Same drivers, the unwinding, and not so much the caseload itself. This really isn't driven by caseload. This is driven by the cost per case coming in higher than what we expected, because we didn't have the clear picture when we built the 25 of what that impact of the unwinding would be on our cost per case baseline.
Can you remind me what was in budget adjustment?
Yeah, because I have it right here. It was a bigger number because we still have a sort of a step down and a lag time of claims coming in.
Okay.
But the budget adjustment number for caseload and utilization was $78 million as opposed to 46.
Okay. So we're not anticipating that for the next year, it won't exceed that 78 of what you anticipated for the rest of.
This is the result of this consensus process. It's based on what we had for most recent quarterly information. So our expectation is that the cost per case is coming up. We are still seeing a decline in our caseload that will run through our 26 position and level out in 26, but through 25, we are coming still down. And then you have the sort of the fruition of that full leveling off in caseload as part of the net number that we come to in the consensus. And it's our best estimate as a group on what we see on caseload and baseline cost per case. Whether or not we are right is part of our process. We are tracking it every month in our dashboard to see if we are on. We are, it feels very, very close. We'll get through January. We've gotten through January and we'll see what that looks like. But that's the process. We had quarterly data through the end of June and through the end of September when we built these estimates. And we'll see what an analysis of the quarter ending December and what January looks like, and report that in our next round of reporting. And so I can't say for sure, we might be up in one place and down in another in terms of our payments, our claims, our pharmacy. But we track what we look like on total month to month, because we do have to dock the ship at the end of the fiscal year.
And now that the unwinding is complete, are we back to I'm going to say COVID, but when we had to stop doing redeterminations, are we back to those pandemic numbers, or are we?
Another sheet here. And see how far back this goes to. We have 2022, we can get, we're looking at like 179,000 people for 2026 as an estimate. That's down from our our mid-pandemic timeframe. I don't, these sheets that we did, maybe they do go back a little bit further here if I pull out another sheet. But we can get them for you, back to however far you want to go, but looking at 19 and 20 will be the right comparison of how many people were on Medicaid before the pandemic started, and what are we back down to in our projection in comparison?
Right, so, and I apologize, I can't remember back to the budget adjustment. So caseload is down, but utilization is up. And have we figured out why it's up?
Cost per case is up. Part of it, cost per case is up on a budgetary basis. We know that when we made the estimates for the 25 budget last year, we didn't have that clear picture on what the underlying stayer population cost per case was when we made the projections. That's part of it. It's an error in what we were able to see and project. And then there are probably also changes because we know that other payers in the system are experiencing, higher than expected payment. But the thing to remember in Medicaid is that a large part of our payments go out as prospective payments to the ACO for the calendar year. We do have shadow claims on that, but the question of intensity of service provided, the one thing we know, we're not seeing a higher volume. It's not being volume driven by more claims per person that is being seen.
But it's a higher cost
Per case. Yeah, it's higher cost per case than we expected when we built the budget.
And so I guess back to the.
And some of it, it's not that we'd have to do a lot of dissecting to compare prior to the pandemic,
Right,
because there's been a
exactly.
lot of price changes
Right.
in that time period as well,
Yeah.
that we'd have to pull out to
And
understand.
I'm just curious to your point, with some of the issues also happening with other payers, should Viva be digging in more to the case cost per case to determine what's driving it? Is there specific codes that are driving it, specific providers that are driving it? Is there something behind it?
I guess the answer is if we can get the data in the way we need it to be confident that what we are seeing is, translating into the budget picture. It'd be valuable to do that. It's a little bit of a matter of resources and time. But it's also knowing how to structure that analysis, given how we seem like we're an insurance company, but we're the benefit program, and it's
Right.
and it's different. It's a different structure than what a commercial insurance company would take in terms of that analysis.
If I can, but you wouldn't have a general sense of, oh, gee, prescription, pharmaceuticals are up, inpatient hospitalization, outpatient hospital. Do we have just a general sense?
We do look at that in our, week to week and month to month. We're comparing it to our payments on average previously. And so as we went through the unwind, that's the hard part to suss out, how much of it was our error, not understanding what the baseline cost of the staying population in Medicaid is versus how much is a change in the field, so to speak. That's where, if you're going to try to determine that, it's a lot of analysis with confidence, that, we can see in this data that, there has been some shift in terms of intensity or the way services are provided. That's the challenge.
I think just that essentially that maybe it's people that stayed on and the ones that dropped off were lower utilizers. But go ahead, Lori, I'm
And
sorry.
how much has it increased since last year?
How much is the budget increase?
Yes, for that line item,
For
caseload and utilization, is that what it's called?
so compared to what we built the budget on, that the $46 million is, it's about 5% of the $900 million of expense in that line item.
So the line item right now is 46 million. What was the line item?
So this is just an incremental change to the
Okay.
total baseline budget. So the baseline budget was $900 million
Okay.
that you enacted.
Mhm.
And we're saying
We need
we,
$46 million
that's
more.
more just to keep the baseline whole. And so that's a little bit, that's,
So that's the amount.
that's the 5%.
And that does not take into account what was in the BAA. So if we take the 900 and we put what was in the BAA, which made it 985, wouldn't 966 actually be lower than?
Yes,
Okay,
yes. And that's because of the declining caseload.
okay.
It's part of the points in time of the budget.
No, I
that are
understand.
hard to
Yeah.
flow through.
I know resources
Yeah.
are hard and you all work extremely hard and I don't want to put anything else on you, but I do think it's interesting that there's an increase with utilization, with caseload going down. And we're not able to tell, to the chair's point, like even in what categories it is to see where the issue lies. Is it just the way it was budgeted, right?
Yeah.
Or is there an underlying issue that's costing us money that we might need in the future? So just want to put that out there. Thank you.
Um,
Can
It
I just say one thing? Sorry. We are looking at it. We are looking. We just haven't identified anything that's glaring to
Okay.
us.
Great. Thank you, Sandy.
So other parts of the program budget, you see the caseload and utilization as item number 3 on our narrative. And you see it in line 307, 309, which are state only. That's mostly the IHIP program. And then you see it also in 310, section 310, and that's mostly the CHIP program, because that's where those programs live. The next item that crosses all 3 of our programmatic areas is the expansion to the Medicare Savings Program that you enacted last year that will turn on in January 2026. And so because of the timing of that, you didn't add money to the 2025 budget, but we need to add, money to the 26 budget for the half year that it's going to turn on in FY26. And you will see this again next year because we'll have to fully annualize the cost of that change by the time we build the 27 budget. And so in section 307, you see the cost of the increase in the Quimby population from 100 to 145% of poverty. In the section B309, it's actually a down in the program cost for B-Farm because increasing the program MSP and has a savings on the B-Farm side. And then in section 310, you see the cost, you also expanded because of the increase in the Quimby population, a big expansion in the qualified individual program up to 195% of poverty. And that's fully federally funded, but that lives in our non-waiver program line item. So those are the pieces of our, the various pieces and where they fall for that action that you took and is now law.
Did we receive, if I recall, we had to have permission from CMS or CMMI, I'm not sure who gives us permission to expand those. Has that happened?
So it's not really permission, it's living within the constructed allocations of those programs. So we followed sort of New York's in enacting that. And so we will be enacting those and we will be getting the builds for the buy-in and we will be absorbing the cost. The question that was most is the allocation for the qualified individuals, which is an allocation nationally. Will we hit up against that at some point in the future? And that's still we don't, given that other states have expanded their qualified individual position, we don't, we're going to go forward and see if, eventually over time, if the rest of the country expanded, what happens in that arena.
Can I ask, if we were to contemplate increasing the Quimby, is that something that could take effect January 1st of 26? Would we need to do anything?
So the ticket, so to speak, in for changing the Quimby is in. I think it would depend on how soon we know. But I assume, if you were changing something and it's a matter of backlog in the access system and getting that in. But if if it's enacted, I want to double check, but it's possible that we could, include it in what's happening through the spring and into the summer. I mean, we are starting to work now to make sure that we can turn it on for January. And so it depends how much you would change things, structurally. So
Well, it's brought to our attention that LIS is currently at 150% of Medicare or poverty level.
Yeah.
So when somebody qualifies for LIS, they send.
We may not remember what that is.
LIS is the low income subsidy for prescription, correct? Prescription medications for people on Medicare?
that qualify.
Yeah, and that's a federal program.
Yes.
And they send Vermont Medicaid a list of all the people, the list. And you have to then reconcile with the people on that list with whether or not they would qualify for Quimby, which leaves this 5% gap.
Yes.
And wouldn't it be advantageous if we just increased Quimby to 150%? So when you get the list, you would know that everybody on the list qualifies. I love saying list. That they would qualify for Quimby automatically, and you wouldn't have to go through. So I think that's my question is, what would it take for us
So you would take
to
it.
contemplate something like that?
So I feel like you've read our V-Farm report. And yes, we do point out that there is a less than ideal alignment between LIS and even the V-Farm breaks of income, and where the new expansion for Quimby is something for the legislature to contemplate. It is not part of the governor's recommend, but if it wasn't acted, if there was a change, we would implement it. It comes with probably a modest cost.
Has that cost been calculated already, or
It was
is that something-
calculated last year. I can tell you that we look at it again, but it's in the vicinity of $400,000 of general fund for the first year. And then it gets annualized, which we will look at for the whole program once we're, another year into data to understand, this is good budget practice. But that's what it would, it would take you taking an action and it being enacted for us to do that. But our V-Farm report, in the back of the report, page 19 or 18, or one of the pages in the back of the report, we do point that out as it's a sort of an awkward misalignment or, less than ideal structure.
Is that something, if we asked for some numbers,
We could do
then
that.
could we get that?
We can take that back as a request.
Okay. I'd like to request that. Okay. Putting it on the record right now.
Ask the question.
Yes, of course.
So if you're doing some sort of, background, implication for this,
increase in the list, would it just not be like an automatic thing? Because right now, this is all done manually. We get a list, Eva gets a list from Social Security. Somebody manually sits down and goes through that list and then reviews that. It's not like an automatic thing that happens.
I think it's, but for the Quimby, what you're talking about is actually changing the 145 Quimby limit to 150.
Correct.
And that is a system change.
Which you're gonna do anyways.
Yeah, so we're starting the process of doing that anyway.
So it would make sense if this were to happen, that they would align at the same time.
That would be better than having to do it again for 5%.
And I work for Viva. One of the things that I found is list gets missed a lot. So that's federal dollars that's not being realized, correct?
To the extent that,
So we have people that will apply for Quimby or Medicaid in general. And one of the things, if they apply for V-Farm as being a screening process, they have to apply for the list. We give them the information on how to do that through Social Security. It's not caught whether that actually goes through or not. So a lot of people are being granted these programs without ever applying for the list.
so I feel like we have a requirement.
It's there,
Yeah.
but you have one person like manually doing this once they get that information. It just seems ineffective to me. That if you're gonna do, I just think you should align these. It's a one shop.
We can't do
I
that.
know you can't, but is it something you would want to happen?
It's not part of the governor's recommended
Mhm.
budget. But if it was enacted, we would implement that.
Okay. It would be wonderful if we could have numbers.
We will respond with that. What you're asking for
Thank
is
you.
that differential between 145 and 150 and what that means for budgetary cost, system timing, and also because of the way you structured the qualifying individual, it's to we go up to the highest amount that we can because tied to the Quimby top end. So that would change a little bit too. But that's all federal funding so that you don't have a general fund impact of that. It's just a spending authority impact.
An estimate also on the number of people that it would affect.
Yes, that will drive the estimate. That's
That's not, yeah.
Yeah.
People would then qualify for Quimby, which is.
yeah, it can be and on the top end of qualifying
Yes.
individuals.
Mhm.
So that's the MSP piece that's built into our budget. We have a few required rate changes. These should be familiar from the budget adjustment. We have to keep up with the indexing. That's just annualizing the indexing for the FQHC, the hospice, and then a small amount of the direct care, which has under a collective bargaining unit, is through the DEVA budget. Most of that lives in the Dale budget, but we have a small increase there. The next line item, which we might want to have a discussion on, is we are including an increase to the budget of 4.5 million for high cost drugs. These are drugs that are in the pipeline, already out, that are not in our base. So for example, the fact that Medicare is covering the GLP-1s for certain cardiac condition, that is not in our base, but we are now covering it. And so that's a cost to our budget. And then there are some very specialized gene therapies that we are coming. Hemophilia, there's a high cost drug related to liver. So we, as responsible budgeters, we have to say, yes, these are coming and we're going to pick up some cost. It's a very difficult estimate to make because, for example, we might have only 1 or 2 people that qualify for the gene therapy for hemophilia, but that can have a cost per case of $2 to $3 million. And so we won't have that every year, but when they come onto our budget, we have to pay for them. And so this is our best estimate of the things that we basically saw in the fall that were coming. For example, the new use of GLP-1s for the sleep apnea is not part of that. And we haven't made an estimate of that, but that will also impact our budget. And those are the types of things that also over time impact our cost per case.
Yeah.
The GLP-1s are now approved for cardiovascular risk factors?
Not a risk,
Or
an actual,
heart disease.
I am not clinical enough to speak to, but whatever Medicare is covering for the cardiac presentations, it's defined. Medicaid will also cover, and we think that's going to be about a $2 million annualized hit to our budget based on the current cost of GLP-1s. It does not cover the cost of GLP-1s for weight loss, which is not a covered benefit under Medicaid.
But now sleep apnea is coming.
Yeah, and we didn't know that in the fall when we built this estimate. And we'll figure out what that estimate is to us and understand it.
Because we all have that.
Type 2 diabetes and general's cardiovascular disease.
Leslie, these are questions.
Yeah, you just mentioned that a case may cost $2 or $3 million. I know in some cases there is insurance, I don't know the right word, to cover that an entity can get to cover high cost stuff. Is that something that DIVA has access to?
So you mean like a stop loss insurance,
I guess maybe that's
like a
right.
commercial coverage would have?
Yeah, maybe you don't have access to that.
Well, we're a government funded
Yeah.
program. The state budget is we do the coordination of benefits with people that do have other coverage and also have Medicaid, because we're the last payer.
Yeah, for sure. I was
things,
just thinking
but-
more about the stop loss that you could protect our budget and your budget by having this high requirement covered by an outside thing. Somehow, but maybe as a government, you can do that. I didn't know.
I don't know if we can't do that. I just don't know if there's an underwriter that would do it for a government program.
That makes sense. Thank you.
Number 7 on our program list is the PRTF budget. So that's funded in 25, and that's shortly to turn on as a program down at the retreat. We funded a partial year of that when we built the 25 budget. And so we have to annualize that budget into 26 for the full amount of beds that we expect to use. And that you might see that as a budget adjustment because it's just turning on and we're, haven't fully settled on a rate yet. So this is a best estimate, but that's we're well down this path and we do have to annualize that cost in our budget. Graduate medical education, you've seen in past years, this is formula driven. It doesn't have a general fund impact because the general fund share of it is provided by the university. We have some net neutral things, which are basically just things moving around from bucket to bucket. They have to be in the right place administratively. The biggest one is the Blueprint Spoke and the Pregnancy Intention Initiative, which is also a Blueprint program. They were being carried up in our regular GC programmatic line item. They need to come down and be in our investment state only. But they're still GC, they're still matchable, no change to the total cost of the program or anything like that. They just have to be put in the right place, but they don't make any change to the budget. And then we have the cost sharing reduction that's fully annualized. This was a BAA piece due to the silver pricing and the gold mapping for January 25. That fully annualizes the savings of the cost sharing reduction because there's far less people in the silver plans now for the people that we have this for. The premium assistance stays the same, and obviously what we face in terms of 2026 and the tax credits is we don't know what the status of the tax credits will be yet. And then we have clawback, which is something we don't control. It's an estimate. We have to pay the money back to the federal government because of stretching back almost 20 years to Part D turning on. We get the estimates from FFIS. We calculate what we need. And that's just money that offsets that cost and has for many, many years. And then the last item, which is not on our ups and downs, but is in the body of the language from the governor's proposed budget, and is part of the one-time list For us, it's $10.8 million of global commitment, one time, for bridge funding for the Medicare funding that flows right now through the ACO for SASH and for Blueprint. This would, because we chose cohort 2 under ahead, this funding is just to create the bridge for 2026 for that funding to still flow out to those entities, the SASH entities and the Blueprint entities that were getting those Medicare dollars. And so the cost of that general fund is the 4.4 that lives in the central office budget, but we will be paying out the 10.8. We still have to figure out the logistics of the payout of that. But that's the one-time item that's included in our budget.
I have a couple questions. So start with Blueprint, unless there's more to go.
No, that's the extent of our money moving pieces.
So, and this might not be a question for you. So I appreciate the 1-year bridge funding, but I understand that the expansion for 2 years that we had piloted, that is not, any extension to that is not being funded.
There's not additional money to that original appropriation for the expansion program. You will see language that says to, carry forward or bring that, we'll spend the entirety of that one-time program, but there is not, when that money is exhausted, that money is exhausted.
On a different subject, are there any rate increases or decreases in this besides the ones that are labeled here, like to the F3HCs?
So there is the underlying that we talked about in budget adjustment of the rate alignment that we do, but those are not, explicit pricing changes. Like when you say increase, so there are none other than what you see here.
Okay. Non-Medicaid transport, new methodology, you all were going to work on that from last year's budget. I'm just wondering if there's been any new methodology that DEVA has.
So we are paying for the non-transport, the rate we're paying on is the non-emergency rate. That was the basis of the estimate that was in the bill, the EMS bill from last year.
Right.
And that is built into our estimate now on the consensus process.
Okay.
At that level, at that non-transport, non-emergency rate. That's what's in our budget.
Okay. And then what about the transportation where it's the reimbursement is paying per person, not per.
So the non-emergency Medicaid transportation, the NEMT.
Yes.
That is level funded. That's a pretty steady, we pay that on a per member per week basis. We have a contract with VPTA that will be up for an RFP this coming summer. We've exhausted the time. We're required to go out to bid after so many years of a contract. That funding is at the level, the baseline level that it has been for 24 and 20, well, not for 24, for 25. It's in the same baseline level for 26. There's no rate increase contemplated for that program.
And is there any still discussions going on around changing the methodology from per member per week to per member per ride or some other methodology that I know?
So there's not for the current contractual arrangement that we have. I think we will be, when we go out to RFP, understanding what the potential other methodologies will be, and they'll be vetted, but not for the current contract that we have. And that contract extends through the end of June 2026. So we would expect to have either a new vendor or a new, contract with the existing transportation vendor in place by, 16 months from now. Given that timing.
Can I just add, I had thought that we had heard from DEVA last year that they were in talks to change the methodology, particularly around the high utilizers.
So we do have
different case.
we have a provision in the contract that we have that would allow a rate increase if we come to mutual agreement on the impact of the high utilizers. That we have until April to come to, we have the data we have to collect and see if that gets triggered. But we did build that into the contract amendment, but it hasn't, we don't know yet if there is a rate increase, and it's relatively modest. If that does get triggered, it will show up as a budget adjustment when we're in next year.
Yeah, I'm sorry, keep going.
Last question.
No, keep going.
And I apologize because I don't remember where I heard this. But I believe I heard that the veterans home is now in our 1115 waiver. Is that an accurate statement?
So I don't know the answer to that.
Okay.
I'm sure that other folks in AHS know the answer to that.
Okay.
And the veterans home is a nursing home, so it's paid out of the Dale budget, long-term care budget.
Okay, so I just was trying to figure out how that affects our waiver. Okay, thank you. I'm done. Thank you very much.
Leslie,
Very quick, but small question. I'm just looking at the V Farm report and it says that the report can be expanded. I'm not hearing it will be expanded. Does something have to happen in order to make, does that need to happen or where does that stand?
You say that. I'm sorry.
The V Farm report that you mentioned, I just have to look at the executive summary and they're talking about would benefit from another year of information gathering before we reported. Is that automatic or something that we need to?
So you had put in a provision that said, come back and tell us what to do about V Farm. Now that we've expanded the MSP.
Yeah,
And we're saying, we can't tell you what to do about V Farm yet.
right.
That's what that's saying.
I hear that.
And you're saying, so we will, I mean, you can,
Do we have to tell you or are you going to do it anyway? Is my question.
you would probably feel more secure if you actually put a provision in that said, please take the provision from last year and follow up with a recommendation. We would probably do it anyway because we did a lot of work on that V Farm report through the summer and fall.
Okay.
But
The safer.
yeah.
So I don't know how we get to, just to be sure we include that in our language.
you had said that there were, I don't think you used the word recommendations, but
There are a certain series of options and then considerations in the back of that report. But we could not come to a recommendation that we had confidence in about what should once this expanded MSP is initiated, what should the future of V Farm look like? We don't have that answer for you.
I hear that and I just don't want to lose track of it. That's all I'm saying.
And what I'm hearing is you still would like a recommendation when there's enough data to make a
When you're able to
recommendation.
make one,
Yeah.
I think we made it to your 2 p.m.
Yes, you did. There's a little bit more reporting pieces.
Is that all right? Dishon, do you-
Yeah, I can say. I don't have a time commitment. but-
Thanks, Evan.
Thank you, Stephanie.
I just breeze through so we can get to Stephanie's part. There are 2 required reporting items that I do want to cover today. And I'm open to having a deeper conversation if need be. The first one is around the coverage for dualist services for Vermont Medicaid that came out of Act 97 last year. And then asks DVA to develop a reimbursement methodology and examine that potential impact for adding coverage. We did that. That is in your books, the annual book on page 54. There's a longer report of that if the committee wants to see that.
What page is that? I'm sorry.
54, starting on 54. And so the other piece too is there is the second item was around reimbursement rates for emergency services that came out of Act 157, which requires the agency to provide a fiscal impact for services if rates were adjusted. We calculated the fiscal, if I could talk, the fiscal estimate using last year's utilization and reprice that at 100% of Medicare's costs. And that fee schedule was not updated in January 1st of this year. The last update was from July 1st of 2024, and it only increased reimbursement for treatment of no transport code. We also benchmarked the treatment no transport code to Medicare Basic Life Support. And the last time that the entire fee schedule was updated was in January 1st, 2023.
I'm sorry, I actually don't have a book, so I'm carrying over. What page is that on?
So required reporting starts on page 54. Doula, the coverage of doula services. And then I just talked about the reimbursement rate of emergency services, which is on
Oh,
page
it's
56.
on the back. I guess I was looking for a little chart to go with it. Sorry. Does anyone have any questions about that?
It concerns me.
It concerns me too.
I need
I don't know
more.
where, it sits. Yeah, I don't know where it sits, like, is it in GovOps or I was a little confused about where that.
I think the recommendation is that we would have to update and we would have to do budget language. But if we did budget language, we would want to know the anticipated cost. So that it would be, instead of being reimbursed at the, no transport, I'm sorry, I'm not getting the words right here. That it was set for not, it's sort of a higher level care rate. So we would need numbers on what it would cost in additional utilization if we recommend that in the budget to clarify that language.
Okay.
So can we add that to
So would it be,
numbers we'd like?
Yeah.
Sorry.
no transport code, BLS would increase to an ALS?
Yes.
Yes,
Yes, thank you.
Yeah. So that's the cure.
That's
Any other questions around those two items? All right. Any other questions for the commissioner? Welcome.
Yeah.
Thank
I was just
you.
thinking-
Are you enjoying the winter?
Yeah. That's what they all say the first time.
Well, let's get good next year, don't worry.
So pretty.
So if I may.
Yes, go
I'm
ahead.
being a little, for want of a better term, dumb. So if we switch to if we're looking for data about the ALS, switching to an ALS reimbursement, is that something we're gonna hear back from you? How does
Yeah.
that work? I just want to understand that.
Yeah, so if we could hear back from you on the expanding Quimby to 150% of FPL, and if we could get numbers on changing from BLS to ALS.
Put it in my follow-up items.
Okay, were there any other requests, recommendations, any? All right.
All right.
Oh,
Thank you.
Thank you.
thank you so much for coming in.
Bye.
Bye. Thanks for joining us.
Thank you.
You survived the unwind.
I did.
That is not my handwriting. It is, I'm sorry, I'm just trying to.
And then
so
other
we're
language
gonna-
about the, sorry, B fund.
Yeah, sort of those whole numbers around Bee Farm, MSP, Quimby,
The whole,
and the whole,
enchilada.
yeah. Okay, thank you. I think we can go off. Our next guests are coming at 2:30.